Okay, thank you, Beth. Basically, on slide 16, we're going to talk about the offering of self-service estimates, and we're going to discuss some of the thought processes and philosophies and discussions. As I mentioned before, we really wanted to be able to commit to patient or community independence, engagement, and autonomy where the patient or community wanted autonomy. Going through the nuts and bolts of the self-service estimator seems that it could be very easy. You just put your top payers, your top services out there and fly. It was really not that easy. With the financial literacy about a bill being very complex, it just even makes it more complex in the self-service world. Although we've had kiosks for our patients, it typically is asked them information that they very simply know, their demographics, or an insurance name, or what their copay is. But they didn't really know all the jargon clinically, even if when an appointment is made. They knew they needed it, the doctor said they needed it, and therefore they scheduled the appointment. When, as I mentioned, we put out an RFP, we were looking for a partner that understood estimates, that understood insurance allowables. PMMC being a national company and being so well versed in it, we used them in the past for other type of contract modeling, patient estimate, insurance estimate information, and they are just phenomenal in not only being able to be flexible and agile, but being able to take all of that information from claims, from contracts, et cetera, being able to bring that information into something meaningful that contract management can understand, our other departments in revenue cycle can understand, and also equate that to what a patient can understand in reference to estimates. And so when we were reviewing and doing the selection, we not only looked at that expertise, but we were also looking at somebody who would partner with us to be able to come up with a patient portal that appeared to be simple and was transparent, that people would not have to understand the complexities behind it. And that is why PMMC was awarded that contract, because of the proven history they had with us and the ability not only to leverage technology, but to tailor it specific to our needs and our population. We also worked with our communication group, our web department group, and also our IT, so that when we were approaching our patient advocacy groups, we could bring with them alternatives and choices so that they all had a thumbprint on what we were developing together. We needed to have an easy feel and touch. We needed to know how much information to put on the website, but also be concise enough so that the patients and community would get the answers that they were looking for and not have so much information that they would be discouraged. I, for one, if I can't do something on a website that I can get in a couple of minutes or less, I typically get discouraged and I pick up a phone call, which was not the purpose of this patient self-serve web portal. Our pre-service teams are very skilled in what we've done before, so they had firsthand knowledge also of all the questions they got asked regarding estimates and where we needed to integrate with financial coordination, et cetera. So we knew it wasn't just about providing an estimate, but we also had to have the web portal engaging enough so that we would be able to provide outreach and financial education to the consumer and make sure that even the uninsured and underinsured could use this website and reach out to people to help them with understanding what the cost would be specific to them. So that's a pretty big group of diverse individuals that we needed to reach out to. So the remaining slides we're going to go through, starting with 17, is going to talk a little bit about the technical aspects and then also about what our thought process was when we were going through the technical aspects. Could you please change to slide 18? Or 17, thank you. So basically I gave you kind of a generality of what we were doing. Some of the stuff is really doing your data mining. What are your top diagnoses and procedures that are being asked about, not necessarily what your top diagnoses and procedures are in reference to what the hospital and your providers are providing. And it was a very interesting discussion because we used PMMC also for our charge master and for contract modeling, and quickly we found that for the CDM and for contract modeling, what was considered the top for them certainly was not the top for the patient estimates. So we had those discussions, which was one of the lessons learned, to be honest with you, because I think people were thinking that they would bring in the same information as it went to payers and diagnoses, and it did not. So that brought some very healthy discussions between both teams, and the result was really, through PMMC and us, is that we really need to keep it in sync, but where do we start with our priorities? So, of course, we started our priority about what do the patients want to see. I mentioned that we needed to be simple. I mentioned that we needed to have common language before, and we wanted to make sure that we were always confirming an estimate. So although in our estimator we provided information, we made sure that we were disclosing that it was an estimate and that we would confirm something in writing if they were more interested in it. You could see that we added 14 payer contracts, and then we also added 34 procedures within 12 specialties to get started with.